Welcome to our IDRPP USU Time to Act Substance Use Echo. I know I'm not Leo and I'm not normally the one who does this introduction, but my name is Tori Coons. I'm the one who sends out our email, so you've probably seen my name before. Since Leo is presenting today, which we are so excited for, I will be doing our intro slides. So if you could please drop your name and contact information in the chat, that would be appreciated. This helps with our networking of each other and helps us contact each other if we have an idea or resource we'd like to share. So please do so as I continue through intro slides. So we do record our echo sessions for educational and quality improvement purposes. By participating in our sessions, you are consenting to being recorded. If you do not wish to be recorded, please disconnect from our session. Echo is an interactive community, so we like to support each other during our sessions. So if you ask a question, we would love to have you do so. If you can turn on your camera and introduce yourself, that would also be great. We love to get to know you more. We also have case narratives and discussions as a great way to get support on difficult cases. So if you haven't presented a case narrative yet, or if you haven't presented one in a while, we would love to have you present again. Because we talk about individuals and cases that we work with, we would love to protect individual privacy. We can do this by avoiding using their first, middle, or last name or any initials. Also, we ask that you de-identify the individual's family members, friends, coworkers, or email addresses, and de-identify examples and situations. If you're unsure about any de-identification that you want to do, you can reach out to a hub member. We all have, or we should have, asterisks in front of our names, just to kind of help us be identifiable to you. So that we have three key components of an echo session. The first is our didactic speaker, which is going to be Leo. He's the one who normally does what I'm doing right now. We love him. And then we have our case presentation and recommendations, and then professional networking. We love all of these different components. They are all so good as we learn together and especially as we network. So just to highlight that. If you would like to rename your profile, you can click on the participants icon in the bottom menu of the Zoom window. And then there should be 3 dots by your name where you can rename your profile in the dialog box. If you do rename your profile, we ask that you include your name, your state, where you work, and then your job title. If you would like to raise your hand later on, you can raise your hand using the reactions window at the bottom of your Zoom window. Leo has asked that we save questions for the end. And so we'll have Janelle monitoring the chat if you'd like to put them in there, or you could raise your hand at that point. We also ask that you maybe raise your hand or do different options like that in case presentation breakout rooms. Echo session etiquette. We ask that you respect the presenter using the chat or raise hand feature to ask questions or to contribute. We also ask that you keep your answers or questions brief and on topic. If you can introduce yourself and your organization before asking a question, that would be lovely. And we would encourage you to turn on your camera, even though it's scary, during the session to help us connect and build community and making networking more meaningful. So we do offer credit for attendance by attending these echo sessions. So if you fill out the survey, which I did drop in the chat at the beginning of this Zoom session, at the end, it allows us to send you a certificate of attendance for completing this time with us and this learning. So that will be emailed to you later on, but that's done through the survey. And I will continue dropping that in the chat throughout the session, so you don't worry about if you've missed that link or anything. So Canvas is the platform that we use to put information or resources from today's sessions and past sessions. If you would like access to our Canvas page, you can email projectscope@usu.edu, which is also highlighted on the screen, and I can send it in the chat later on too. Case studies are where we share information about real life, hear from our colleague, and receive valuable feedback to take and apply. If you're interested, and we would highly, highly suggest that you guys do this, you can reach out to projectscope@usu.edu to get the form and fill it out so you can do a case presentation. And we love it when you guys do, because you guys bring such interesting points to the table and things to talk about. We do ask that you follow our social media pages. This is where we post crucial updates and reminders, as well as like good information from our session, whether that's through impactful quotes or other things. And then these are like a good way to stay connected with one another and to do further networking. We have a Facebook group that we run that's also a great place to just talk about some of these things in addition. And that link is going to be in the chat as well. So that's the end of our slides today. Let me see if I can get rid of this. So I'm going to turn the time over to Leo, our fabulous presenter that we're so excited for.
Thank you, Tori. I'm just gonna share my screen real quick. Okay. Me and Janelle were practicing this, so I'm hoping that you guys can see it. But I'm Leo. I'm the project assistant here for Project Echo up at the IDRPP at Utah State University. And I just wanted to start off the 2026 series with a little overview, or I guess maybe a large overview of how substance use disorders may impact the family unit. I mean, a lot of the times people really don't realize that a parent with a substance use disorder or maybe even a sibling can really alter family dynamics, which can directly affect some of the children or people that you work with. And I kind of began doing this research after just wanting to know more about the connection between neonatal opioid withdrawal syndrome and kind of the early childhood sphere and kind of how those relate. So let's dive into it. Here's just a little agenda of what we're kind of going to go over, just family
Leo,
engaged developmental.
your slides aren't sharing yet.
Oh no. Are you sure?
I'm not seeing them. Is anybody else? Okay, Stacy says no. I saw her head shake no.
Oh no. Here.
So try sharing it.
Oh, I don't think I think I forgot to press share. That's so funny. I told you I'm just so excited. I'm ready to dive right in, honestly. Here are my slides.
Perfect. Now we can see them.
Thank you, Janelle. Sorry about that, guys.
No,
But
you're
here's
good.
just that little agenda, just family engaged developmental monitoring. Then we'll go over kind of what is the substance use disorder, some of the data that surrounds substance use disorders here in Utah. Then we'll talk about some of the stigma and then some provider steps that you can take. And I kind of wanted to first go over the five key components of early identification as a quick refresher. And those are first, developmental promotion. The second one is family engaged developmental monitoring. The third is developmental screening. The fourth is referrals for needed supports and services. And five is developmental evaluations and receipt of needed services. That's kind of just what early interventionists or early childhood providers would use to kind of I guess, spot developmental delays, but our focus for today will be on family engaged developmental monitoring because as at the heart of this framework is the belief that families are not just participants, but they're basically the leaders in their child's developmental journey. And furthering family engaged developmental monitoring entails a really collaborative process where families and providers will partner to observe, reflect, and respond to a child's developmental needs. And this sort of monitoring really requires a deep family engagement, which really elevates the role of the family here. A great tool for family engaged developmental monitoring is probably the CDC's Learn the Signs Act Early Tracker and app. I mean, it's a family-friendly way to track your child's developmental milestones and really spot those developmental concerns. So overall, family engaged developmental monitoring really affirms that family-driven and strengths-based approach, which highlights what's going well. It surfaces family priorities and builds long-term confidence in a parent's ability to advocate for their children's goals and needs. And just to jump further into family engaged developmental monitoring, Passarelli in 2023 really summarizes this holistic approach of family engaged developmental monitoring that we'll be following for this presentation really well. And they tell us that child development requires a holistic approach across the social ecology that may contribute to overall health and well-being, and it's also inclusive of those social drivers. And Passarelli continues stating that switching to a focus on family well-being, inclusive of family priorities and needs such as concrete and social supports, can lead to positive outcomes for all children. And this can remind us that children's development doesn't happen in isolation. It's really shaped by a complex web of influences such as family dynamics, community community environments and broader societal conditions. And those are what we call those social drivers of health. And a substance use disorder can really disrupt the stability, relationships, and resources that children rely on for healthy development. That's why a holistic approach is really key. It's one that considers not just the child again, but the entire social ecology that's surrounding them. And it's just kind of like if a part of that web begins to be torn, that web may no longer stand. So that's why we should be following the framework we're following today of family engaged developmental monitoring, as it really allows us to equip families with tools and just resources for improved wellness and positive development. And I really wanted to jump into what is a substance use disorder. And just to define it clearly, it's a medical condition that affects a person's brain and behavior, leading to clinically significant impairment, including health problems, disability, and failure to meet major responsibilities at work, school, or home. And when this occurs in the family unit, especially during pregnancy, it can have significant developmental implications for the child. And early interventionists and providers alike really have this unique opportunity to provide holistic support, which may look like identifying developmental delays early on, connecting families to appropriate resources and services, maybe teaching strategies that promote healthy development and well-being, or maybe you're educating caregivers and parents on how substance use disorders impact relationships such as parenting, bonding, and child outcomes. And a consequence that may stem from substance use disorder is prenatal opioid exposure, which can lead to neonatal opioid withdrawal syndrome, which is a condition where newborns experience withdrawal symptoms due to opioid exposure in utero. So we'll explore this more in detail in the next slide, but what I really want to drive is just to recognize the impact that early interventionists may have in both prevention and support. They can foster trust, they can share knowledge, and they can empower those families when they're following a family engaged developmental monitoring framework. And now I want to preface this and say that neonatal opioid withdrawal syndrome does not mean neglect or bad parenting. It really just reflects a physiological dependence and it's not a moral failing. And furthering, NOWS, which is neonatal opioid withdrawal syndrome, and I'll just refer to it as NOWS, is a qualifying condition in Utah to actually receive early intervention services. And some of those common developmental concerns that may pop up in a child with NOWS can include behavior. So an exposed child may have challenges with attention and impulsivity. They may also struggle to calm down when upset or overwhelmed. They may have some sensory challenges where the child shows strong preferences to how they interact with their environment. So for example, they may actually be sensitive to noises, touch, or textures of foods. They may also crave a lot of movement or want to chew on non-food items. Another concern may be learning. A child that may have NOWS may also have a need for school supports, such as an IFSP or a 504 plan to access their education appropriately. A child may also have vision concerns, where a child may be at risk to fail visual exams. A child also may experience eye drifting or alignment issues, eye movement control, and even clarity issues. And there may also be speech delays in both expressive and receptive language, which are pretty common. And this includes difficulty speaking, understanding instructions, and later literacy skills like reading. And there also may be concerns with that well-child medical follow-up. A child with NOWS may be at an increased risk of missing that routine well-child visit, which is really critical for monitoring their development and catching those concerns early. And that can happen in a lot of ways. It may happen by a family affected by substance use disorder. It may be facing instability, and that may be why they missed that well-child visit, because maybe housing insecurity is making it a lot harder for them to attend their regular appointments. Caregivers may also feel really overwhelmed or disconnected from healthcare systems, especially if they've had really negative experiences in the past with some of the healthcare systems that they've come across. And in some cases, children actually may even be placed in foster care or with relatives, and continuity of care can be disrupted. So, as interventionists and providers, it's really critical to recognize some of these patterns, and by recognizing them, we can tailor supports and guide families towards resources that really promote healthy development. And maybe some symptoms of NOWS that you may want to look out for. It could be inconsolable crying, irritability, tremors or jitteriness, and maybe poor sleep or frequent yawning or sneezing. Those are just a few of the symptoms that you may be watching out for. But then again, NOWS is a qualifying condition to receive early intervention services. So I think it provides a really great opportunity for collaboration. between interventionist and maybe CPS, or I forget the organization title, but we'll touch on that later. And each professional really plays a unique role in promoting healthy development and addressing specific concerns when aiding a child with NOWS. And that might be having a developmental behavioral pediatrician monitoring overall development and health. They may be creating a long-term care plan or connecting family with resources. An early interventionist can support early learning. They can help with school transitions, and they can assist in creating IFSPs. An SLP, a speech language pathologist, can develop plans for expressive slash receptive language. They can look at speech fluency and articulation. An occupational therapist may want to address some of those sensory needs that we spoke about before, and they may want to build some coping and self-regulation skills. And a child developmental psychologist may want to support those behavioral and social emotional developments, and they may also want to help with those peer and caregiver interactions that that child may be having. And an optometrist may want to help with those vision concerns. Again, they may want to assess and support vision health, including eye movement and clarity. And moving on, now that we have kind of our definitions and framework, and now that we've seen the team that you may want to have if you're trying to aid a child with NOWS, there are two really critical theories that are crucial to help us understand how and why substance use disorders impact the family. And our first theory is attachment theory, which provides a way of understanding the development and quality of relationships between family members. John Bowlby developed this attachment theory through studying mammalian species and humans, and he postulating that at the time of an infant's birth, the primary relationship, usually with the mother, but not always, serves as the template for all subsequent relationships throughout the life cycle. And this relationship forms a subsystem within that larger family system. It is through that primary relationship between infant and mother that infants actually learn to communicate and relate to their environment through crying, cooing, brooding, and clinging. If the child experiences the primary caretaker as more responsive and nurturing, a secure attachment may form. And if the child experiences the primary caretaker as maybe more unresponsive, then a insecure attachment actually may form, which can result in a variety of problems, which can include anxiety, depression, and maybe even failure to thrive. Attachment theory really posits that the quality of the parents' attachment system that developed in infancy will affect the child's ability to form healthy attachments to even their own children and with other adults. So healthy attachment is like an immune system because, oh, sorry. Sorry, I thought I heard someone come off mute. Okay. So in healthy attachment, it's almost like an immune system because just as humans need a physiological immune system to fight off disease and illness, the relational attachment system provides protection against those psychological, maybe concerns and illnesses. And our second theory is the family systems theory, which stems from the idea that every system is made of parts that affect one another. Just like a cell works as a system in biology, a family functions as its own system. So you can't fully understand one person, especially the child, without understanding their whole family picture. Family systems theory really has three key components, similar to general systems theory, if you know about that one. And those key components include one, homeostasis, where families will try to keep things stable even if the stability isn't healthy. For example, children will take on adult responsibilities to keep stability, homeostasis, when a parent struggles with substance use. And although it helps the family feel stable, it may be what's actually keeping the problem growing. The second kind of key component of the family systems theory is feedback. So family members influence each other in ongoing feedback loops. One person's behavior affects another's, which then reinforces the first person's behavior. And these cycles really shape relationships, including the parent-child attachment. And the third component is boundaries. So healthy families will have more transparent boundaries where parents function as the adult unit and children are allowed their space to be kids. And in families affected by substance use, those boundaries may often break down, and those roles are really convoluted between parent and child. Roles become more permeable within families going through substance use. So, our second theory really serves as a reminder that children's behaviors often make sense when we look at the whole family system, not just the child alone. So, this is why family engaged developmental monitoring is super important. And sorry, I'm just pausing a little because I didn't know if anyone had a question. I did hear someone come off mute, but
There haven't
Okay.
been any questions yet, Leo, so
Okay. Okay. Thank you, Janelle. I'm sorry. I just keep hearing
no,
that little
you're
feedback and
good.
I'm like, I think someone's trying to ask something, but so now that we have really our framework and our theory set and most of our definitions set as well, we can really incorporate how families may be affected by substance use. And that may look, and first, it's substance use disorders really affect more than just the person who misuses those substances. They can potentially affect the person's entire family as well. It influencing the breakdown in the ways in which family members get along, communicate, and bond with each other. A family, again, is a system consisting of different parts, the family members, so a change in one part can really cause changes throughout the system. And second is that substance misuse among parents with young or adolescent children affects family dynamics, often because substance misuse makes it hard for parents to fulfill their child-rearing responsibilities. So, for example, parents with substance use disorders often have affective dysregulation, which is an inability to manage emotional responses, leading to reactions that are too intense, prolonged, or inappropriate that can really make it hard for their children to develop those healthy attachments, form those trusting relationships with others, and learn how to regulate their own emotions and behaviors. Children will often develop complex systems of denial to really protect themselves against the reality of their parents' substance use disorder. And third is that substance misuse by parents is itself considered an adverse childhood event. And other adverse childhood events really include domestic violence and child abuse and neglect. Parental substance misuse is associated with significantly increased risk in children of actually later developing a substance use disorder in the future or an impairment in the ability to cope with stress, which can affect with relapse. And with our links connecting the family unit and substance use disorders, what do the numbers tell us? And that's when we can really jump into the data. Because first, in any given week, opioids are actually responsible for 8 out of 10 adult drug overdose deaths in Utah, and many of these deaths actually occur in the state's most sparsely populated counties. Second, in 2022, there were 541 drug overdose deaths in Utah, with 74% of those deaths involving an opioid. And that number actually increased in 2023, where there were 606 drug overdose deaths in Utah. And third is in rural Utah, is that rural Utah actually has a really high rate of substance use disorder, yet limited amounts of resources. I mean, Carbon, Emery, and Wayne counties, three really sparsely populated areas in east central Utah that have some of the highest rates of opioid-related deaths in the state, actually only have 14 health centers and clinics that offer varying levels of behavioral health and substance abuse care. These facilities are actually scattered across about 14,000 square miles, which is an area roughly the size of New Jersey, Delaware, and Connecticut combined. So as a result, individuals really seeking care for opioid dependence often must travel an hour or more to receive counseling or treatment in those rural areas. A person in a rural area may even travel 4 to 6 hours for specialty care if it's not available to them locally. So when we really talk about these overdose deaths or when we talk about overdoses, we're also talking about children who are may lose their parents, their caregivers, and maybe even their stability. In rural Utah, where resources are scarce and distances are vast, early childhood providers may really be the only consistent adult presence in a child's life. You're not really just educators. You essentially can be a lifeline. So we kind of just looked at how those opioid overdose rates, particularly in rural areas, continue to impact families across Utah. And substance use disorder is really just one piece of a broader set of challenges affecting family health and stability. Another critical issue is maternal mortality. And mental health conditions, substance use disorders, and obesity are the most common contributing factors to maternal death. So as we can see from the chart, substance use is actually the second leading contributing factor to maternal deaths in Utah. So furthering that, Utah is experiencing a small but steady rise in maternal mortality. So with 87 Utah residents dying during pregnancy or within 1 year of their pregnancy. And Gimple in 2024 defines maternal mortality, telling us it's the death of a woman during pregnancy, at delivery, or soon after delivery. Any such death is a tragedy for the pregnant individual, their family, and society as a whole. We also must recognize that 7 out of 10 of these deaths were preventable. So, although substance use disorder is one of the leading causes of maternal deaths in Utah, unfortunately, the accessibility to treatment for maternal substance use disorders is a major challenge. Barriers may include limited availability of maternal health focused substance use treatment and detox facilities, maybe limited healthcare provider training on maternal substance use disorders, or maybe even social stigma can hold a mother back from really accessing that care in her community. And most maternal deaths really occur not during childbirth, but actually in the weeks and months that follow. This postpartum period is a crucial time, not only for maternal health, but for the development of the mother-infant relationship and the overall stability of the family. So, what can early childhood providers and providers alike do during the perinatal period? And early childhood providers should really be engaged during this time, supporting that mother-infant dyad in meaningful ways. You may be screening for postpartum depression and other complications, educating families on infant care and feeding, and referring them to additional services like lactation support or mental health care. Your work may also include development of nurturing interactions, helping establish feeding habits, and providing information on immunizations. In many situations, the early childhood provider, such as the interventionist, serves as that crucial point of contact for families navigating challenges during that really sensitive perinatal period. So, in understanding the contributing factors to maternal mortality, such as mental health conditions and substance use disorder, can really help providers recognize risk and just respond with empathy and connect with families to the support that they need. And I wanted to talk a bit about, or yeah, just a bit about stigma because I think it's always important to talk about stigma. Because as we've seen, substance use disorders really can affect the whole family system, not just the individual in active use. Along with clinical and familial challenges, families with substance use disorder may face really harsh stigma from their community and peers. Stigma can prevent people from seeking help, disclosing their situations, or accessing services. And stigmas really run deep and they can affect a whole family unit. Stigma is this negative attitude or belief toward a certain individual or groups of people who possess characteristics differing from social norms. This negative perception often leads to discrimination, exclusion, and or marginalization. And I just wanted to ask the audience a few questions. You can put your answers in the chat. But I just have two questions to ask you guys, and I wanted to just ask, how do you define stigma, and where do you see stigma in your work, whether in the classroom, childcare setting, or the healthcare environment? Because I think a lot of the times most of us don't really see or we don't recognize that, stigma is happening within these places that we work in. And I think it's crucial to, kind of start talking about stigma and get rid of the stigma that surrounds some of these ideas. So I'll just give you a minute if you would like to answer those in chat. And I would definitely say you could raise your hand and come off mute. I just can't see everyone. So it's been a little weird. It's a lot different being on the other side, I guess, being the didactic presenter.
So, Leah, you're having negative thoughts. I see stigma among families more.
Thank
I
you.
see stigma with people even trying to get assistance. People don't know who to talk to, that sometimes they're afraid, sometimes they're fearful. They're afraid of having their children taken away if they report things or if they talk about having mental health difficulties or substance use difficulties. Pretty common.
Oh, great. And then Elizabeth, you have your hand off. If you want to come and give one of your ideas.
Yes. Repetition. Okay, let me explain. I've seen among families, especially these two family, this family I know, they started fostering care their kids, and then from parents they were drug users. They then adopted the kids. That we're talking about 5 different kids. So one of them, he's only 4 years old. At the beginning, he shows that he could not talk. It was very slow talking. His sister used to have reflex when she was sleeping. Now, the young girl, she's growing,
Yeah, so
going, and then the young boy is completely like said 5 words. So they
Yeah,
go to
so Elizabeth, you're really seeing like that repetition and
you
other
have to
things.
when he gets upset. So the mom says, "Stop, stop, stop, stop,"
Okay.
and then he stopped. And
Yeah.
then with the one that he goes to learn how to speak, he said he can express when he's hungry and when he's angry, and then
Great.
he knows my
Okay.
name. He
Yeah.
knows
Awesome.
Yeah.
I teach
Well,
him say my name.
yeah, thank you, Elizabeth, for those
You're
ideas. That's
welcome.
really interesting. I
Repetition.
do have kind of an example that may relate to that, and just an example kind of surrounding stigma. So I'll just tell you guys that right now. And Sarah is a mother of an infant living in a rural town. This is a mock example, by the way. There's no real people in this, but she's been struggling with alcohol use for several years. Her alcohol use has escalated to the point where her family and neighbors have noticed Sarah's maybe erratic behavior, frequent absence from family events, and an inability to keep up with those household responsibilities. Over time, as Sarah's drinking worsened, the judgment from family and community members began to pile on. Her husband John begins to hear whispers of judgment behind his back, and relatives are suggesting that Sarah's behavior reflects poor character and that she's not trying hard enough. There's really this growing assumption among her community that if she were a good mother, she wouldn't be drinking so much. Sarah is not invited to social gatherings anymore, and people are now reluctant inviting John to social outings, with some persons even implying that Sarah is a bad influence on their children. The stigma around Sarah's substance use creates a ripple effect that can impact that entire family unit. John feels ashamed, isolated, and is reluctant to ask for help. And Sarah's infant is also being affected as Sarah feels inadequate to care for her infant due to the opinions of her community. She may also be scared to ask for help. As Tim mentioned, a lot of times community members may just really be scared of that stigma surrounding, asking for help or asking for help regarding substance use. So stigma really leads to judgment, which can exclude a certain individual from communal opportunities. The stigma in this example also led to shame. All of these components in Sarah's situation really have led her and John to not seek any help. Instead of being able to face substance use disorder as a mental health issue, the family has to face moral judgments from their community regarding substance use, which really just deepens their sense of isolation. And this is why we should really try reducing stigma. And reducing stigma really starts with the language we use, because research from Johns Hopkins in 2025 tells us that using first person language like a person with a substance use disorder is far less stigmatizing than terms like substance abuser. Language really matters because it can shape our treatment and our view of others. Trauma-informed care is also another key tool that we can use to reduce stigma. When conducting a visit or working with the family in general, providers really should recognize those adverse experiences that a kiddo may be experiencing. And those ACEs, adverse childhood experiences, can have lasting effects if not recognized early on. Children who lack a trusted adult to help regulate those emotional responses may experience toxic stress, which can lead to long-term developmental and health challenges. And Utah's maternal mortality review committee actually emphasizes the need for a more multifaceted approach. So one that really includes early screening, coordinated services, and stigma reduction to better support pregnant and postpartum individuals. And SAMHSA also has really this wonderful framework that outlines the four key principles to trauma-informed care. And those principles really include realizing the widespread impact of trauma, recognizing its signs and symptoms, responding by integrating knowledge into practice, and actively resisting re-traumatization. So ultimately, I guess education and awareness can really be powerful tools to reduce stigma. So by understanding what substance use disorders are and how they affect families, we are already taking those steps in trying to reduce stigma in communities. And when you learn about a new resource and connect a family to it, you're already making that first step. You're already making a major impact. You're showing that family that it's okay to seek help when needed. And as early childhood providers reduce stigmas and provide resources, they may also actually play a key role in prevention. And their key role in prevention actually comes from positive factors. And the Positive factors or protective factors are conditions or attributes that reduce or eliminate the impact of risk factors. So while risk factors increase the likelihood of poor outcomes, protective factors help buffer families and children from those risks. And the 5 key protective factors we focus on are just concrete supports, social connections, cognitive and social emotional competence, knowledge of child development, and parental resilience. These are really the building blocks of strong families, and they're central to preventing substance use disorder and other adverse outcomes. In early childhood work, our goal is to be preventive, not reactive. That means supporting families really before a crisis occurs. One way to do that is by ensuring basic needs are met first, those concrete supports like housing, food, and safety. Without those, it's difficult for families to focus on emotional or social needs. And also taking a holistic view is really key. Families are complex systems again, and protective factors just don't exist alone. They interact across emotional, social, physical, and developmental domains. When we support the whole family, meeting practical needs, fostering relationships, and building resilience, we're creating conditions for long-term well-being. We also can build resilience by pointing out a child's personal strengths. When we highlight what's going really well, we help them develop a sense of capability and confidence. And fostering supportive relationships within the family can also open doors to just broader community connections. Encouraging those social interactions while maintaining consistent structure and boundaries helps children build social and emotional competence. Even simpler activities like going outside together, doing crafts, or sharing meals can strengthen the family unit and promote healthy development. I always like to use the broken wagon wheel example. That's probably why you're probably thinking, why is there a broken wagon up on my screen right now? But I kind of use it as an analogy because if one wheel on that wagon is broken, that wagon isn't moving. If one part of a family isn't doing well, then the whole family is at risk of not progressing. This highlights the importance of family cohesion and emotional responsiveness. A child who is struggling, whether emotionally, socially, or academically, can affect the entire family's ability to thrive. Positive factors is like repairing that wagon wheel. And this wagon analogy also can relate back to that family systems theory we were talking about earlier, because when one person in a family begins to change his or her behavior, the change will affect the entire system. So perhaps maybe one of those wheels doesn't have enough oil. That change might affect the whole wagon itself. And I just have a short video kind of explaining how prevention is really an upstream effort, because by addressing those root causes of public health challenges, interventions have the power to strengthen and protect communities and individuals. So I'm going to play it. I think the last time I tried playing it, I don't know if it shared the sound. So Janelle, if you could tell me if there's sound, I'd appreciate it.
Nope.
Oh no.
So go to your 3 dots.
It's not pausing.
Oh, shoot.
Here, I have an idea. Do I have to share my sound?
Yep, you need to share your sound and then go back to the slide,
Yeah.
the video.
Ooh, awesome.
Yep,
Are you-
now it is.
All of us want to keep our kids and communities safe and healthy. An important step is to learn about preventing substance use disorders and to understand that the adolescent brain is more vulnerable to alcohol and drugs than the adult brain. The earlier someone starts using substances, the greater their chances of developing a substance use disorder. 90% of those who have a substance use disorder started using drugs and alcohol before they turned 18. 90%. So what does this mean? Prevention is about delaying the onset of first use or pushing it back as long as possible. Whether alcohol, tobacco, or marijuana, the most commonly used substances among teens. Protecting the brain during this period of development is an important part of prevention. The adolescent brain is rapidly developing, learning and changing all the time. It can learn a language or a musical instrument more quickly than an adult brain, but it can also be harmed more easily. The brain continues to develop until a person is in their early to mid-20s, with the regions of the brain that keep emotions and impulses under control and help us make decisions among the last to develop. This is also why adolescents are more likely to engage in risky and impulsive behaviors, such as trying drugs and alcohol in the first place. Early use of alcohol or drugs can disrupt brain development in ways that increase a person's risk of developing an addiction later in life. Other factors that put an adolescent at risk, besides the age of first use, include caregiver substance misuse, trauma, and a lack of social attachments. These are called individual factors. And they're part of the big three in preventing addiction, along with environmental and genetic factors. Environmental factors include high drug availability, a lack of laws and enforcement, and social norms. And then there are genetic factors, which research suggests accounts for about half of a person's likelihood of developing a substance use disorder. While we can't change our genetics, knowing about a family history of addiction can help empower us to make different decisions about our substance use. For every risk factor, there is a protective factor to counterbalance it. Prevention focuses on strengthening the protective factors that we can control to decrease the likelihood that a person or a community will struggle with addiction. Together, we can solve this. Join us.
Sorry, I'm just gonna move on before it just starts playing or I have more technical difficulties. So again, that was just a short video really showing how prevention may be important. And so if prevention is really about getting upstream early, then early childhood is where it starts. That's why it's important for providers to understand the principles of substance use prevention, where we can lay the groundwork for lifelong resilience. There are 7 principles that we'll go over today. That might sound like a lot, but I'll try and shorten it a little. So our first principle is intervening early in childhood can alter the life course trajectory in a positive direction. So prevention can have strong effects when applied early in a child's life. Substance abuse and other problem behaviors that are seen in 10 years have their roots in developmental changes that occurred earlier, as far back as before birth. Prevention can be effective at any age, but it can have particularly strong effects when applied early in a person's life and when development is most easily shaped. Our second principle is intervening early in childhood can both increase protective factors and reduce risk factors. Risk factors are qualities of children and their environments that place them at greater risk of behavioral problems and substance use disorders. Protective factors are the qualities that help young people cope and adapt to certain risks. Interventionists should focus on building protective factors. All children will have a mix of both risk and protective, so interventions aim to shift the balance toward those protective factors. Our third principle is intervening early in childhood can have positive long-term effects. It really sets the stage for positive self-regulation and other protective factors that reduce the risk of drug use. You're building resiliency while negating risk factors. And principle 4 is intervening early in childhood can have effects on a wide array of behaviors. It can even have an effect on the behaviors not specifically targeted by a specific intervention. Behaviors are linked to each other, thus risk factors for substance use may simultaneously put a child at risk for other problems such as mental illness or difficulties at school. Intervening to prevent one undesirable outcome may have a really broad chain effect, improving the child's life trajectory in multiple ways. Risk factors for substance use disorder also put a child at risk for other behavioral and physical problems. Our fifth principle is early childhood interventions can positively affect children's biological functioning. Interventions in childhood can improve physical health as well as behavioral and psychological outcomes. For example, one intervention for young children in the foster care system looked at cortisol level, a biological measure of the stress response. Over time, the stress response of children receiving the intervention showed better regulation and became similar to that of children in the general population. Our sixth principle is early childhood prevention interventions should target the proximal environments of the child. The family environment is the most important context across all periods of early childhood development, and thus parents are a major target of many early childhood interventions. As the child grows older, they will typically start spending more time away from home, for example, attending preschool, elementary school, and so forth. Interventionists should focus on the most relevant contexts, the home, school, daycare, or a combination of those three. Our last principle, our seventh principle, is positively affecting a child's behavior through early intervention can elicit positive behaviors in adult caregivers and in other children, improving the overall social environment. Behavioral changes in children and the adults who interact with them can influence each other. It's mutually self-reinforcing. Improving the child's family or school environment can, over time, cause the child's social behavior to become more positive and healthy or pro-social. This leads to more positive interactions with others and improved social environment as a result. In short, early childhood providers are not substance use specialists, but they can be prevention specialists by virtue of their work. By supporting strong relationships, increasing positive factors, reducing stress, and promoting healthy development, providers help build resilience and reduce risk of negative effects later on in the child's life. And we touched on this when I was explaining what a substance use disorder was, but I wanted to add a lot more to it because, as we know, children with parents who misuse substances are at an increased risk for negative consequences, such as poor school performance or lack of coping strategies. A provider may want to keep these kind of strategies that I'm going to give you in mind to provide quality service to families that may be going through substance use disorder or families in general. So just know the facts about substance use in pregnancy. Substance use can affect families in many ways, and when it is appropriate, share information that is easy to understand with the family. Show them strategies to implement when you aren't there. Second is to learn about local support services. Find local services for substance use, mental health, parenting support, and early intervention for newborns. Many people, up to 70% with a substance use disorder, also have a mental health concern. So be ready to help families find and access these resources. Three is stay informed about how to help families. Maybe learn a new skill such as motivational interviewing to better support families in need. Fourth is understand your agency's policies and reporting requirements. Know your agency's policies and procedures for when a report to child welfare may be needed. Understand state, territorial, or tribal laws about reporting substance use and families' rights. Get guidance from a supervisor or colleague if you need to, and ask about trainings to better understand your responsibilities as a mandated reporter. And five is support parent-child interactions. A provider may want to model behavior for parents to try. The goal is to help caregivers notice, respond to, and connect with their children in ways that build safety and emotional regulation. And I thought I had another one, but I think I forgot to add it, but I did have another one. And the last kind of suggestion, the seventh suggestion, is to collaborate with CPS, medical providers, and treatment programs. This may look like sharing developmental concerns about the children, communicating about routines, safety concerns, or changes in the children's behavior, participate in team meetings to ensure the child's developmental needs are included, and a provider may help those organizations understand what supports the family needs to maintain safe and predictable caregiving. But what an early interventionist provider or early childhood provider may not do is they may not diagnose substance use disorders, as diagnosis requires special credentials and falls under medical or behavioral health professionals. So a licensed psychiatrist or a licensed psychologist is the one to diagnose those. You may want to refer resources, but you will not diagnose. The second is an early childhood provider does not provide addiction counseling. Early intervention's role is really to support the child's development in parent-child interactions, not to treat the parent's substance use. And three is a provider does not want to directly intervene in a parent's treatment plan. EI provider's role is to collaborate, not to intervene. Collaboration is really done by reinforcing child-focused routines and supporting parenting skills that complement, not replace, a treatment plan. And EI providers can not give medical or mental health advice about substance use. An early intervention provider can encourage those families to follow medical recommendations, but they can't provide them. And last is manage safety plans related to substance use. So safety plans involving substance use are really overseen by CPS, treatment providers, or legal systems. So early intervention providers may participate in team meetings and share child-focused observations, but they can't create, enforce, or monitor those safety plans that were already created by CPS, treatment providers, or those legal systems. Their responsibility is really to support safe caregiving routines and not to manage that risk related to substance use. And I just wanted to talk about how does the substance use echo help? I'm the project assistant for Project Echo, as I said in my introduction, but this, I guess this network is pretty close to me. I've just done a lot of research on it, and the Substance Use Echo really helps providers interested in learning more about substance use disorder by providing sessions pertaining to specific topics on substance use disorder. So just last year, we had I think almost 11 or 10 or I think almost 12 sessions just relating all to substance use disorder and just kind of providing strategies with strategies and resources for providers to use in their daily work. We also record these sessions and post them onto our website, Canvas, and YouTube for future viewing. And the Substance Use Echo provides additional resources as well. If you navigate over to the IDRPP's website and you click on Project Echo, we have a little additional resources tab where it's actually divided into all of our 4 networks. And by those networks, you can click and just find a lot of really great additional resources that the team gathers from maybe different presentations or something that maybe was sent to us through email or maybe we've seen it online. And I just wanted to show maybe an example of maybe one of those additional resources that you can find. I really enjoyed this video of Louis, Elmo's dad, having a difficult conversation with Elmo. It shows how we can start these conversations early. So I'm just going to play that now.
You played Monster Ball terrific today, son. I'm so proud of you.
Thank you, Daddy. Elmo had a lot of fun with Carly today.
Oh,
Well, she's a great friend.
yeah, she sure is.
Elmo knows that Carly's mommy was away for a while, but now she's back. But Carly's mommy looks and acts different than she did before.
Yeah, Carly's mommy seems much healthier since she's been back.
How come Carly's mommy had to go away?
Well, son, Carly's mommy has a kind of sickness, and she had to get some help.
Sickness? Like when Elmo has the sniffles?
Oh, no, it's not that kind of sickness. Carly's mommy has a disease called addiction. Addiction makes people feel like they need a grown-up drink called alcohol or another kind of drug to feel okay. That can make a person act strange in ways they can't control.
But why doesn't she just stop?
Oh, it's not something you can just stop doing, not without help from the right grown-ups.
Daddy? Will Carly's mommy get better?
Well, she's working hard on it. She's taking good care of her body and mind so she can stay healthy and make good choices.
Oh, good. Elmo's really happy for her.
Oh, me too, son.
Yeah.
Now, you want to show me how you bounce that monster ball?
Oh, yeah.
So just that short little video, maybe on how to have kind of those sorts of conversations with a child, those difficult conversations that you may come across. And here are just some of the helpful resources that were gathered that can hopefully maybe be of use to you and maybe the families that you work with. I even know that I think NCSACW is doing a presentation for us in June or July. I'm already mixing up the dates, but I'm super excited for that. But there are just kind of resources that, relate substance use in early childhood and maybe how you can start that prevention work early and through your own work. And those are my references. And yeah, that was all I had for you guys today. Thank you. I'm going to see if there's any questions in the chat.
Thank you, Leo, so much. I wanted to hop on, not hop off, sorry. Hop on and ask if there were any questions and take those.
Sure. I'm reading in the
doesn't seem
chat.
like
I'm
we
from
have-
I'm
Yeah.
from Rich County originally, and we have 0 resources for substance abuse and travel long distances to seek help. Getting into specialized care has improved, but can still be difficult. Yeah, literally. And that's kind of the focus too. I really want to look into those rural communities and see how we can help rural communities access those resources because, yeah, it's just that access to specialized care but it can still, yeah, yeah. I can see stigma among families.
There are any questions, you can come on in the chat or raise your hand. Kurt.
Yeah, Leo, I just want to tell you thanks for that great presentation. You said something in your presentation, I put it in the chat, about confidence. I've worked in early intervention with kids with disabilities for 25 years, and I think the ability for providers to instill confidence in this population, people with substance use challenges, as well as disabilities or any other marginalized population, because society would tell them, you're not good enough, you got major problems, you can't handle this, whatever it is, the message they get from society. And being able as a provider to, one, be knowledgeable enough to give them resources or solutions that they can use, but number two, being compassionate enough to help them understand that they need to have that confidence and that they may not be great at this, but they're kind of great at this. And so finding ways to build that confidence. So I just wanted to point that out, that I appreciated you bringing that up, because I do think that's one of the keys to being, number one, a good provider, but to also helping people be able to make their lives better in the way that they want to make it better.
Thank you. I'm sorry, I'm reading the chat too, just on like kind of the examples of the stigma that you guys are seeing in your communities. But yeah, I'll just give it a tiny more moment if somebody else has a question, and I'm also the case presenter for this session, so I'm gonna pull that up. Let's see.
Just while we're waiting, Leo, when you were talking about attachment styles and how they're an immune system in like children's lives, I was like mind blown. I actually spent a lot of time last semester, I'm at Utah State, researching attachment styles and kind of their impact more on like adult relationships. But I was like, oh my gosh, to think of it like an immune system, amazing, amazing idea. So thank you for that.
Thank you. Oh, thank you. I appreciate that. Okay. So I'll just start off with the case presentation. Again, I'm Leo. And
Leo,
there we
before
go.
you start, I just
Yes.
want to just congratulate to Stacy. She just put in the
Oh,
chat.
sorry.
One of her own children suffers from addiction, and finding help was nearly impossible. The stigma was really hard in a small community, and she's proud to say that he has been clean for
Oh.
7 years. So
Thank
celebration right
you.
there.
Thank you for sharing that, Stacy. That's amazing that he's been clean for 7 years. And I really do I'm sorry that resources are just so hard and that stigma and those small communities can just be so ingrained, you could say. So I'm really happy and glad that your son has been clean for 7 years. And yeah, that's perfect. That's awesome. Thank you so much for sharing.
And Leo, I think it's really important to note that on your key points at the very start, where it says about just that early identification or that promotion of it. I mean, I think that the more we talk about these conversations around substance use, how it impacts the family, is where then sometimes those services will start coming when we're all aware of it. So I really appreciated you kind of starting that conversation with us.
Thank you, Janelle. Sorry, I'm the worst person too at like taking compliments, so I just always kind of sit here very awkwardly like, thank you. I don't know what to say, but I really appreciate all the comments that you guys have and you know, I'm excited to be here. So I'm gonna start on this little case that I have. So there are two children. There's Ava, who's 3 years old, and she's showing regression in potty training, tantrums, and fearfulness during parental conflict or conflict in general. Then we have Jonah, who's 10, and he has in a sensitive attachment period, and he's basically exposed to inconsistent emotional availability with his parents. And there's Marcus, who's the father. He's 34. He's on leave from his job due to an injury and daily alcohol use and occasional misuse of painkillers, and he's emotionally inconsistent. Then we have the mother, who's Leah. She's 32, and she's a stay-at-home mom. She states feeling overwhelmed, isolated, and she's showing signs of anxiety and burnout, which is really concerning. And there also has been CPS involvement following an alcohol-related incident where Marcus passed out while caring for the children. Oh, it's not moving. Hold on. There we go. Okay. And so just these primary area of concern. Ava's regression and fearfulness may indicate early trauma exposure. Jonah's attachment and development may be disrupted by inconsistent caregiving and just that household stress, which increases risk for developmental delays, emotional dysregulation, and long-term relational difficulties. And some of those goals and some of the barriers. So the goals is just to strengthen the predictable routines for both children, maybe to increase emotionally responsive caregiving from both parents and to just support co-parenting consistency to reduce conflict and instability. Another goal is just to also ensure safety and reduce the children's exposure to intoxication or just unsafe supervision. And some of those barriers to kind of maybe achieving those goals are just Marcus's ongoing substance use and limited insight into its impact, Leah's emotional exhaustion and anxiety around the system, financial stress due to unstable employment opportunities, maybe some limited extended family involvement and support, and CPS will sometimes create additional stress. And Marcus and Leah kind of just fear CPS, and that leads them to fear the healthcare system as well. Leah has tried implementing structured routines, but struggles to maintain them alone. And Marcus really engages positively with the children when sober, but becomes irritable and emotionally distant when using substances. So the family has not previously engaged in early intervention or parent support services as well. Just for the community discussion, I do have a lot of questions that but I like the suggestions. So it's great to have these questions and just what strategies could help reduce Ava's regression and tantrums while maintaining a sense of safety and predictability, and how might early childhood providers help both caregivers understand Ava's behaviors as communication rather than misbehavior. Then with Jonah's attachment and developmental progress, maybe what everyday interactions like feeding, diapering, or play can be used to promote secure attachment with both caregivers, and maybe how can early interventionists coach caregivers to be more responsive and attuned during moments of the child's stress or distraction. And the last kind of topic for the questions was just engaging both of the caregivers. So what community resources or supports might reduce caregiver stress and indirectly benefit the children's development? And how can early interventionists encourage shared routines and co-parenting practices that strengthen the children's sense of stability? So,
Lovely.
and
Thank you, Leo, for presenting that. I've got the breakout rooms all set up and ready to go. Hub members, you should have received a little message about what topic to cover. If you have any questions, though, you can hang back for a moment and I can answer them. Does that sound okay, Leo?
that's good. That's perfect. Thank you.
Perfect. Then I'm going to open the breakout rooms right now. Let me just remember to put the recording back on. Welcome back. I hope you had a great conversation in your breakout room. Sorry for a bit of confusion in getting things set up with our hub members. So as far as I know, Lisa was the one who conducted it. Do you or Leo want to share what you guys talked about? I think you guys were group one.
Leo, I hate to have you talk, or I'd love to hear you talk, but I hate to put you on the spot to talk again, but you took notes, so can you recap?
No worries, no worries.
Okay.
I think a really important point that I guess stuck with me a lot is that some of these strategies and things take a lot of time to implement, and it takes a lot of time to see, positive change within a family. So I think it's just important and critical to recognize that this process doesn't happen overnight. Like it just takes a lot of time and a lot of building with the family, and just kind of speaks to that holistic point that, when you help kind of maybe even one member of that family, it could have just this huge ripple effect on the family. So, and it just takes a lot of time and stuff. So I hope that was just like one small idea, but there were a lot of great ideas in our breakout room as well.
I'm very happy to hear that you guys had such a good conversation. That's a great idea. I love it. Janelle, do you want to share what you guys talked about? I'm not sure if you took notes, but
I did. I finally found a piece of paper over. I'm in a different location, so I was struggling with that. So ours had some really great discussion around just how to support that social emotional development and really talked about identifying their emotions, modeling what their emotions are. So I see that you're happy, I see that you're sad. Modeling what they can do different next time or how they can seek out the adult's help. And then, like Leo was talking about, how it just needs to, it takes a long time, but we also need to continue to work on being consistent across settings. So it's really important if you're doing something in a childcare setting, or wherever, that you're also helping the parents learn those strategies as well. And then Natalie made a really great point when we're talking about behavior, is to have the parents really identify specifically what the behavior is. So then you can break that down of how, kind of going through the ABCs of behavior with the family, and it would help reduce some of their kind of overwhelm feelings around the misbehavior. So
I love that. Thank you for sharing, Janelle. I'm sad that we didn't get to talk about the third kind of grouping of questions, but it sounds like we've got some really great ideas and resources. So that'll be great for Leo in his case. And also that these ideas will be shared via Canvas, our Canvas course. So if you would like access to that, you can email projectscope@usu.edu, which has been dropped in the chat before, but we'll also be sending out a post-session email on Friday. So you can look for that and respond to that if you would like to get access to Canvas. I'm going to close up the session with a reminder that our next substance use session is going to be on February 11th, where we're going to talk about stigma and silence with Sydney O'Shea. It sounds like it's going to be a really good session. I know Leo probably has a lot more to say on that, but I think he's served his time today, which he loved doing, and we loved having him. Is there anything else that we need to announce, or are we good to wrap up? Perfect. Well, thank you guys so much for coming. We love to have your ideas and your stories and your comments. So we'll see you next time.